But again, this is a very small number and hard to extrapolate to larger groups of patients. Because of the difficulty in staging, the way we stage, being from the government, we're one of the few people in the government who try to keep things simple. So we try and have a very simple staging system for our patients, which is at the end of the operation, we try and stage to the extent of disease. So again, I do not feel that anyone can be rendered disease-free or an R0 resection, but what we consider stage 0 is no evidence of microscopic disease or macroscopic disease visible at the end of the resection. Stages 1 and 2 are patients with limited, less than 1 centimeter tumor deposits in the abdomen, and stage 3 are tumor deposits greater than 1 centimeter but less than 2 centimeters. We consider these to be patients who are suboptimally debulked, but still patients who potentially benefit from therapy. But stage 4 patients who have no ability to get below 2 centimeters in tumor, we will not administer intraoperative chemotherapy, and the role of the surgery at that point is palliative as far as removal of ascites, gross tumor burden, and potentially intestinal bypass. Our system is relatively simple. Patients undergo an exploratory laparotomy, lysis of all scar tissue, removal of as much tumor as possible. All patients get no lumpectomy, and we feel very strongly in organ preservation. The majority of patients who have local recurrent disease will recur in the abdomen, and subsequent surgeries are frequently necessary. But the removal of all involved surfaces that would be required in a majority of patients would also take away the majority of intestinal length, and that is not compatible with life. So we very much are reluctant to do extensive bowel surgery unless it is needed to render patients down to less than 1 centimeter of disease. We then place 2 catheters through the abdominal wall, connect the patient to a very simple heat exchange roller pump circuit, and for 90 minutes irrigate